All right, well, welcome everyone to our module 3 with Dr. Westley on stewardship in skin and soft tissue infections. I will hand it over to Dr. Westley in a second, but I did want to mention that we are offering CEUs for these sessions. I'll drop the link in the chat, and then afterwards we'll be sending the recording and information out to everyone who registered. So with that, I'm going to hand it over to Dr. Westley.
Okay, great. Thanks, everybody. Well, we'll move on to our module 3, skin and soft tissue infections. Let me hide this banner. If I can.
Only showing on your screen, but I know it's.
Yeah, I got to get it out of the way, otherwise I can't see my slides. That is weird. Go away. Hide floating meeting controls. Hey, there we go. Okay. So today we are going to review skin and soft tissue infections. Really not a lot of compelling new information in the last few years, but I'll try to incorporate a few things. We need to look at categorization of these. Purulent and non-purulent are the main categories that drive how we pick antibiotics. And then recognize some conditions that will increase the risk of complications and we need to think about as we use antibiotics. Identify some warning signs of severe infections, and then we need to spend some time discussing diabetic foot infection and briefly comment on injecting drug users. So skin and soft tissue infections, very common, multiple words or categories used to describe these things that are confusing and not actually overly helpful. Terms such as erysipelas, impetigo, abscess have specific connotations and impact on antibiotic selection, but these terms are not always applied correctly, so it can be a little confusing. We'll try to talk about that. And you could have multiple features. You could have an abscess with cellulitis around it, for example. So when people use the term impetigo, what does that really mean? These are very superficial, lifted up, crusting, oozing, sometimes either blistered or honey-colored surface lesions, typically Staph aureus group A strep, and it's quite uncommon for MRSA to cause impetigo, thankfully, although it can. If there are multiple lesions and they are not responding to usual treatment, which would be cephalexin or topical treatment, a culture can help just make sure it's not MRSA. Very small single lesions, topical mupirocin antibiotics works just fine, but for multiple lesions or severe ones, oral cephalexin is typically what's given. Now, cellulitis is that more red, hot, tomato red, fiery looking, painful skin. And multiple things can mimic cellulitis, which I'll show a picture in a minute. So you can get venous stasis, sunburn, and stuff. It can look like cellulitis. Not all red skin is cellulitis. When cellulitis occurs, it can be non-purulent, which is the sort of classic thing where you would have a confluent red leg that pops up very quickly, usually within hours or a day, especially between the ankle and knee. Or you could have pus, like a central lesion with a furuncle or an early abscess, and then have redness spreading around that. So you can have purulent or non-purulent. So if the cellulitis is spreading around a central lesion, like a furuncle, carbuncle, which is basically a bigger, hard, swollen area, that's typically a Staph aureus infection, and about 40% of those are MRSA. However, if it's just ankle to knee, especially in somebody who has chronic edema at baseline, maybe they have some heart failure, lymphedema, liver failure, then they'll have smooth, kind of diffuse redness ankle to knee, and those are virtually always beta hemolytic strep. When we talk about erysipelas, that is also cellulitis, but it's a sort of subset where the very surface of the skin gets lifted up like an orange peel, very tender, red, fiery, and then has a sharp edge to it. A lot of cellulitis doesn't have that, but the very superficial erysipelas form does. And that's virtually always group A streptococcus. So the national guidelines have not changed from 2014, and they still categorize by purulent or non-purulent because, again, you basically do not need MRSA coverage for non-purulent disease. So if there's a draining lesion with pus, that's purulent. And, you know, it's very helpful to culture these on the first episode because if the patient comes back over and over in the following months, they will have the same thing. So culturing it the very first time to know whether it's MRSA or MSSA is very helpful. Now, the emergency department doctors do not like to do that because it means that they have to follow up on those cultures or be responsible for them. And their literature suggests it doesn't change management because they just give everybody MRSA drug. But if somebody's given Bactrim, for example, and then they have a side effect of the Bactrim, it's very helpful to know whether they actually have MSSA or MRSA, because if they've got MSSA, they could just be switched to Keflex, for example. For mild disease, you don't need antibiotics for a tiny little, let's say, ingrown hair, a tender ingrown hair or something. No antibiotics would be needed. But if there's redness 5 centimeters in diameter, then antibiotics are felt to be beneficial. I'll show you that literature. Bactrim or clindamycin have typically been given, and there's a head-to-head study on Bactrim and clindamycin I'll also mention. Now, a lot of us are using linezolid 600 milligrams twice a day because it's generic, it's cheap, it's well tolerated, very effective. Adding cephalexin to trimethoprim sulfa is not beneficial. So even if a patient does not have purulence, if they are given MRSA treatment anyway that they probably don't need, there is not known to be any benefit of adding cephalexin to Bactrim. That's been demonstrated. You do see that done sometimes. There is classic or older school literature suggesting that trimethoprim sulfa is not very active against beta hemolytic streptococcus, though we think that's more of an in vitro assay issue than a real clinical issue. And so both drugs should not be given. For severe disease, this is sepsis. So if you have purulent skin infection and sepsis, that would be a severe purulent skin infection. And that's where we recommend blood cultures like we do for all septic patients, vancomycin to cover MRSA and MSSA and strep. And then we would switch to orals when they're better. There's randomized data for outpatient treatment for non-severe disease that 5 days is as effective as 10 days. And the slides will have the resources for that study if you want it. Do you have to give antibiotics to all uncomplicated abscesses? When I was in medical school in the early 2000s in Seattle, the surgeons would frequently drain large staphylococcal abscesses, especially in injecting drug users, and not give systemic antibiotics and felt it was not necessary. So do we need antibiotics for abscesses that are drained? Actually, the data is conflicting. There were some old randomized controlled trials that suggested not, but in 2016 and 17, some studies suggest a small benefit. Here's one of them from 2016 of 1,200 patients that are 12 or older. And this is if the abscess was 2 centimeters, which is pretty small, just about an inch. And they randomized them to Bactrim or placebo for 7 days, and they were all cultured. They averaged 2.5 centimeters, so pretty small. Cellulitis was typically about 6 centimeters, so these were usually that kind of moderate category. 45% were MRSA, and the cure rate was higher with antibiotics than with placebo, but only by about 7%. So 80% versus 73%. Statistically significant, but the majority of them got better with drainage alone. This is the data in that study, just to prove that I'm not making it up. Now, for non-purulent disease, they also have categorizations of these. Mild, you've seen somebody in clinic with some redness on the lower leg, came on quickly. Tender, they might have some mild chills or something. Cephalexin or amoxicillin are legitimate options because this is streptococcal disease. Moderate infection would mean that a patient has a substantial portion of the leg involved, they're worsening or they're not able to tolerate oral antibiotics. They would give IV antibiotics, for example, with cefazolin. And if they do not improve, then at that time, that's when we would start thinking maybe there's a deeper purulent focus or some confusion regarding the disease. They could call an expert or imaging could be considered. The majority of patients, nearly all patients admitted to the hospital with soft tissue infections get imaged, but the majority of them do not need imaging, and they will get better with antibiotics. when antibiotics are given for non-purulent disease, the redness does tend to get worse for the first 24 to 48 hours. So it will spread, but the patient will generally get better. Fever will go down, white blood cell count will go down, and they'll feel overall better even as the redness worsens the first 48 hours. Spreading redness with improving patient does not suggest that they're worsening. Now, severe infection would mean that they are sepsis, physiologic derangement, tachycardia, low blood pressure, illness, sepsis criteria. And then we worry about actually could there be a necrotizing skin and soft tissue infection. So we're going to talk about those later. Just a reminder again, as I mentioned, not all red legs are infected. I got to go to the Galapagos for Christmas, and there's a type of blue-footed booby, and there's also red-footed boobies. They all had red feet. None of them had cellulitis. Not all red legs are infected. This is a picture of venous stasis dermatitis. This is a person with chronic edema. The legs will get red when they're held dependent, and then they'll get a little better when propped up. They will have looked like this for weeks or months. They won't have fever, flu-like illness, systemic illness, and there could be tenderness, but it will not be severe pain. This is venous stasis. It's not cellulitis. Okay. That should not be treated with antibiotics because it's not an infection. So here's 2015 New England Journal of Medicine study that was really exciting because it was a randomized trial of old, cheap, generic medicines that nobody makes any money off of. So it was really heartening to see that a study like this was actually done. And it was randomized with 500 patients. Half of these patients had purulent soft tissue disease, but that means that half had non-purulent cellulitis. And they gave them either Bactrim, and that was just one pill twice a day, not 2 pills, just normal 1 pill twice a day versus clindamycin at 300 TID. And there were equivalent cure rates and equivalent complication rates. This was moderate disease, but they excluded people that were septic, so they couldn't have a high fever. And here's the intention to treat and evaluable populations that showed that basically cures with either drug were about the same in the 80 to 90% range. So knowing what we know about antibiotics and what the optimal use are, we actually know from Tim Jenkins' study, I think from Colorado, that using a stewardship approach to antibiotics can help. They actually used broader antibiotics in this study that we are advocating currently, but they showed that antimicrobial stewardship can have a big impact. So they instituted a guideline, and then they looked at their treatments pre and post guideline. And what they were trying to do is minimize the use of CRP, x-rays, and blood cultures, which are not usually required. Septic patients should have blood cultures, but people that are stable and not septic do not need blood cultures when they're admitted for cellulitis. They discourage CT or MRI imaging. They discourage superficial swabs of skin, which are not useful. We culture abscesses that are drained surgically. We don't culture surface skin. They tried to just use vancomycin. They were trying to get people away from broad gram-negative coverage, essentially. Now we know that we don't even need vancomycin. Most of these patients with non-purulent disease, you can just use cefazolin. That's what they did. And they basically showed that they substantially shortened the duration of antibiotics given, and they substantially reduced the broad aerobic gram-negative drugs used in the institution by 30 or 40%. So big impact in this study from about 12 years ago. So which patients should we worry more that could have complications or that we need to be extra thoughtful and make sure that we're treating aggressively? If the patient has soft tissue infection around their eye, that can be a different process. You can have a blocked lacrimal duct or severe sinusitis underlying that, and the redness might not actually be from a skin bacteria, but it could be from infection deeper inside, depending on imaging and findings and exam. So sometimes those patients will need broader antibiotics, such as ampicillin sulbactam or ceftriaxone. Now, mastitis or cellulitis of the breast, also normally on the surface, there won't be a fluctuant abscess or purulent drainage, but there is so much empty space in those ducts to hold pus. There frequently is staphylococcus, even when you can't see purulence on the outside. So that's really a different process. Mastitis typically happens when lactating and breastfeeding, but not always. Head and neck abscesses or parotid abscesses in the face. They frequently have staphylococcus, but also can have oral flora because that whole parotid gland is connected to the oral cavity. So these patients also oftentimes need MRSA coverage plus coverage such as ampicillin sulbactam. And then infections around the GI tract, especially around the rectum or in the genitals, are very mixed. That's not the cleanest area of the body, as we all know. So when infections happen in that area, they can actually be quite severe, and there can be staphylococcus and or mixed like gram-negative rods, anaerobes, etc. Then finally, patients that are very immune compromised or immune suppressed based on treatments, based on transplants, or based on underlying or inherited immunodeficiency could be at risk for different organisms, and they can't really all be put into one category. Most of the time, we would recommend talking to an expert, either a transplant expert, an infectious disease expert, when these patients are being seen. They may or may not need different treatment. If a kidney transplant patient has a small furuncle, it's likely to be staphylococcal, but if they have a severe infection, it could be a bit more complex to treat them. In rare cases, there could be molds or other weird organisms. Now, when a skin and soft tissue infection is necrotizing and actually results in tissue death, tissue ischemia, it can be very rapidly progressing and life-threatening. Necrotizing fasciitis being the sort of most famous and feared. In this case, bacteria and their toxins grow and are released right along the deep fascial plane, sometimes deep to the fascia, right between the fascia and the muscle. And it's very severe. The most common form we see a lot in Alaska is group A streptococcus, just one organism. That's type 2 monomicrobial disease, and the mortality is quite high. Now, we occasionally see polymicrobial infections, and these are more often in the perineum, as I just mentioned, but that would be called type 1, and gram-negative rods and anaerobes can be seen in these. Clostridial disease could be seen in those, and they oftentimes are gas-forming. Klebsiella pneumoniae is an example of a gram-negative rod that can make a lot of gas and cause a necrotizing soft tissue infection. Sometimes you'll see that in immune-compromised patients like transplant patients or cirrhosis, patients with cirrhosis. So you typically see one or more of the hallmark features, although no one finding is perfectly sensitive or specific. But oftentimes, because the infection is really deep down underneath the subcutaneous tissue, down near the fascia or muscle, that the surface is very hard and woody and spreads rapidly and is very painful. But when you look at the skin doesn't look bad. So a lot of providers will look and go, oh, that doesn't look too bad to me. But then when you feel it, it's really hard and the patient's exquisitely sensitive. The patients are virtually always sick. And this can be demonstrated by both labs and by vital sign findings. And there's a score I'll show you. In this small percentage, 20% or something, where gas is actually formed in the tissues, sometimes you can feel that, like a Rice Krispies, you can feel popping inside the soft tissues when you push on them. It's called crepitus. Or the skin can actually start looking purple or black. When you touch the skin, it can be either cold or it can be black and almost look gangrenous, and the blood flow does not return to the skin. You can push and you can't see redness blanching when you remove your hand. There can be blisters. Now, strep cellulitis frequently causes blisters. After a couple of days of treatment, the very surface epidermis will lift up and there will be flaccid blisters. But when there are deeper blisters in the subcutaneous tissue, that's very concerning. And Fournier's gangrene is a subset of necrotizing soft tissue infection, and it's down in the scrotum or vulva, and it usually spreads around the rectum. And there's mixed stuff, can be Clostridium anaerobes, gram-negative rods, like I mentioned. So we find this score helpful because just having an objective number that somebody can put in a chart note can help with inertia with our surgical colleagues, getting some help assessing with a sharp instrument if the skin's alive or not. So this is a laboratory risk indicator in necrotizing fasciitis. The ED doctors like this, but the surgeons also appreciate when we put it in the charts. And it uses these objective numbers. You can't really argue about what a white blood cell count or a sodium or a glucose is because it's in the computer. If the score is over 6, the positive predictive value for necrotizing disease is 92%, but the negative predictive value is 96%. So if you're under that, it will argue against having a necrotizing infection. So scores over 6 are particularly concerning. 6 or higher is seen in 90% of necrotizing fasciitis. So only 10% have a score less than 6, but it's still not a perfect score, not a perfect test, but it's helpful when there's ambivalence, right? So a small number, about 8%, will have a score over 6 and won't have necrotizing fasciitis, but at least they will get appropriate evaluation and management, and you won't miss a life-threatening disease. These are the scores here. You don't need to memorize that. The way to do it is to just go to Google and put in the score in the search banner, and you'll find it. This is MD Calcs, and you basically just scroll through and put in the lab values, and it will give you the score, and it actually will also interpret the score and give some recommendations. So we'll find that helpful. How about imaging these patients? Nobody can argue what is the white blood cell count or glucose number because it's in the lab reports. But oftentimes, radiologic interpretations of a scan are somehow felt to be definitive information about a patient, which would obviate even the need for a bedside evaluation or physical exam or something, and that is not true. So CT scans and MRIs can be helpful because if they show fluid along the fascial planes, if they show brisk enhancement of the fascial tissues, or if they show gas in the tissues, then that's a very specific and strong finding for necrotizing disease. But both the sensitivity and the specificity of those findings are poor. They are not good, despite what some radiologists have told me repeatedly. And the problem that I have with some of these things is that oftentimes the imaging studies will tend to delay surgery. And in very clearly evident cases should just go right to the operating room. If somebody's got a score of 6 or 7 and there's disagreement about what's going on, the surgeons will frequently want imaging, but the imaging should not delay or obviate the need for surgery. It really ought to be to help target where to go with surgery to determine if there's a necrotizing infection or not. Right. So the clinical impression has to drive the surgical decision making. And normally what the recommendation is that if there's areas of the skin that look particularly bad and the LRI-NEC score is 7, for example, that the surgeon should make some incisions in those areas, and then they can just actually use a tool or finger to make sure that there's not necrotic tissue dissecting along the fascia there. The damage from this, especially with group A strep, which is what we see, is actually toxin mediated. The bacteria release streptococcal toxic shock toxins. These make these patients systemically sick and also damage the tissues and lead to necrosis. If clindamycin is given, because it's not a cell wall drug, it's actually a drug that reduces and impairs protein synthesis inside the bacteria. In vitro, you can measure toxin production from the bacteria and see that the toxin production diminishes, and animal models show that giving that drug improves survival when they're sick with severe group A strep infections. And we think the same thing clinically occurs because multiple studies, observational studies, suggest clindamycin decreases mortality in invasive group A streptococcal infections. So patients with known group A streptococcus or strong suspicion for group A streptococcus with unstable vital signs, we would like to add a protein synthesis inhibitor. The good news is that linezolid also appears to do this. In vitro, impairs streptococcal toxin production, and there are several series now suggesting that clinical outcomes are non-inferior to clindamycin when used with a beta-lactam. So for example, you give ampicillin or ceftriaxone plus linezolid, the outcomes appear similar to clindamycin. And this is good because this is good for a couple of reasons. Clindamycin certainly causes Clostridium difficile in some cases, the drug we're kind of trying to avoid using when we can. And in Alaska, group A streptococcal resistance is about 20%. So about only about 80% of group A streptococcus is actually susceptible to that drug. Whether in vitro susceptibility correlates with response to clindamycin clinically is not entirely known, but it's counterintuitive to use a drug for a critically ill patient when there's a 20% chance that the organisms are resistant to the drug. So there has been a move towards using linezolid rather than clindamycin for severe necrotizing soft tissue infections empirically for the first couple of days. So we use either clindamycin or linezolid with the beta-lactam, and we wait till a patient's improved. They usually are having surgeries done, oftentimes daily, and then we continue the beta-lactam alone after the first couple of days. You could use cefazolin, ceftriaxone, ampicillin, whatever, plus clinda or linezolid, then you stop the second drug and finish with amoxicillin or cephalexin, something like that. Typically, treatment's about 10 days. Occasionally, if surgeries are having trouble getting control of the disease, the treatment might be longer. We try not to go more than 7 to 10 days. So, linezolid plus piperacillin and tazobactam when a patient's first presenting, because until you have either blood or tissue cultures, don't really know for sure if it's type 1 or type 2 disease, though in Alaska, 95, 98% of cases are probably group A streptococcus. If that antibiotic's being given, if linezolid and zosyn is being given to a patient because there's concern for necrotizing fasciitis, there has to be a surgical consultation. It's really not okay to give those antibiotics but not have a surgeon involved, thinking that those antibiotics are going to fix necrotizing fasciitis because the treatment's surgical. If a patient has moderate or mild cellulitis, they do not need linezolid and zosyn. They're on linezolid and zosyn. It suggests that there's severe disease that needs surgical evaluation. Otherwise, it's sort of like only having one foot in the bathwater. Now, I'll just mention this isn't really stewardship, but this comes up a lot in ICUs with these severe infections. Can anything else be done when somebody's very sick with group A streptococcus? This means multi-organ system dysfunction, shock, and when there's so much toxin that's resulting in that, you can actually see that patients will get wheezing, they'll get nausea, vomiting, or diarrhea, like a toxic illness, and then the skin oftentimes, not the cellulitis area, but actually much of the entire body will be red, hot, warm. We call it erythroderma, and typically the conjunctiva will also be red and injected, and those are signs of toxic shock syndrome or toxemia. And staphylococcal toxic shock also can occur, but typically group A strep is what we see. And there's really not randomized data. There's observational data that suggests that IV immune globulin might help bind those toxins and improve outcomes. So for streptococcal toxic shock, many experts would go ahead and use immune globulin 1 gram per kilo on day 1 and then 0.5 on day 2 and 3. Sometimes I'll give 1 dose, and if the patient's rapidly improved with surgery and vasopressor stop and the patient's better, I would not continue it necessarily. But I probably do this a couple times a year for patients. Okay, now let's move on briefly to diabetic foot infections, and we should probably spend some time on this because this is one of the more common things we deal with in the hospital from a stewardship perspective and on the clinical service because it's so common and probably overly managed or overly antibioticized. And there are really good guidelines on how to do this, so we shouldn't have to make it up. And so I'm going to try to go through those here. So there was an updated guideline in 2023, International Working Group on Diabetic Foot, IWGDF. First point is really critical. Not all diabetic ulcers are infected. This may sound intuitive, but it doesn't seem to be to a lot of providers. If there's an ulcer from somebody with a numb foot walking around and the skin is worn through to the subcutaneous tissue, they will develop an ulcer. An ulcer is infected if there's red cellulitis spreading around it, going up the foot and leg, or if there's substantial pus, drainage, infected material coming out of the ulcer. But an ulcer that is deep but dry is not considered infected. So that's the first thing to talk about. Signs of infection are redness, warmth, tenderness, pain, induration, or purulent secretions. So now we categorize diabetic foot infection. So that's an ulcer in somebody with diabetes who is infected. This isn't a red leg between the ankle and knee of someone who happens to have diabetes and chronic edema. We're talking about an ulcer, so a diabetic foot tissue breakdown with active infection around it. So we categorize these as mild, which is if there's redness less than 2 centimeters around the ulcer. So if you have an ulcer in the subcutaneous tissue only that has less than 2 centimeters of redness around it, that would be a mild disease. A moderate disease would be more than 2 centimeters around it. So these are typically the whole foot or the lower leg is getting red with cellulitis. Or it's an ulcer that's infected, so purulent drainage, and deep structures are involved. So either a lot of cellulitis or deep structure involved. You can have an ulcer with pus going all the way into the midfoot bone or into tendons and muscle, and that's a moderate diabetic foot infection. It's not severe, even if there's deep structures and pus coming out of bone, if the patient's stable. If the patient is not febrile, doesn't have white count at 25 and tachycardia or something, then that's a moderate infection with deep structure involvement. Severe infections requires the patient basically to be septic, and that's the same category we've used throughout the last 2 modules. Severe means patient's septic, needs to be in the hospital, right? So first off, we'd really like to know what organisms are in these infections because it will help us optimize the antibiotics. And the guideline recommends that we should culture the infected material before starting antibiotics in patients that are not severely ill. You don't want to just swab skin though. So what we want to do is you want to have the ulcer cleaned at the bedside, like by wound care, clean out all that surface stuff, and then we want to culture the deeper tissues down in the area of concern. We don't want to just pick up all the superficial slough and culture that. We want to culture the live tissues down at the base. However, if a patient is septic, the antibiotics should not be delayed. So if somebody has a fever and the white blood cell count's 20 and their leg is red from the foot to the knee, they need antibiotics quickly. They shouldn't be admitted to the hospital and not given antibiotics. The guidelines also recommend we do x-rays in all these patients. If there is concern that the ulcer goes to bone or that the bone is involved. Not every person with a diabetic foot ulcer needs an x-ray, but many should get x-rays if there's concern the bone should be involved. The reason to have concern bone should be involved is not just because there's an ulcer and the person has diabetes. It's because the ulcer should be assessed, and if the ulcer appears to go to deep structures such as bone, then that can be done. Not everybody needs that. If there is a strong suspicion that there's bone involved, but the x-ray does not show an abnormality, an MRI can be done. Not all these feet require MRIs, although it seems like almost every diabetic foot infection admitted to the hospital gets an MRI. One of the other problems is that MRIs are very, very sensitive for any sort of edema or trauma to the bone. And you can have a swollen edema in your bone if you jump hard and land on your bone, if you injure your bone, if you have Charcot foot changes. So the MRI is great to rule out a bone problem, but many people with diabetes have abnormal MRIs and do not have bone infections. Okay, so we've categorized these now, mild and moderate. The guidelines are quite clear that we're worried about gram-positive organisms, gram-positive cocci, specifically beta strep and Staph aureus. So for a mild clinic outpatient foot infection, cephalexin is a reasonable empiric target if the patient has not had MRSA before. For moderate infections, we talk about using amoxiclav or amsulbactam. If there was MRSA recently in that patient, linezolid would be another option. And if it's known that there's Pseudomonas in that wound previously, recently, Piptazo would be an option. When patients are unstable, just like with the neck fash patients we talked about, we recommend linezolid or vancomycin plus Piptazo, but they also, of course, need an urgent surgical consultation because if a patient is septic with a diabetic ulcer, then they're going to need some source control and could get very sick without appropriate surgical evaluation. Now, here's another thing we see a lot, and we're working hard at all these hospitals to help with, is how long do we treat? And again, it's okay to use oral antibiotics. I'm going to get into that again in a second. So for these mild clinic ulcers with a little purulence or a tiny amount of redness, 1 to 2 weeks of treatment is recommended in the guidelines. Moderate to severe infections, treatment is usually 2 to 3 weeks. When bone is involved but not fully resected, meaning surgery is done, we think there's bone infection and the margin at the edge of the bone is involved, the guidelines actually recommend 3 weeks. I'm going to show you the table in a minute. If all bone is fully resected, then the infection's cured, and basically a short course of antibiotics is all that's required. This is the table here. And again, they talk about infection severity. And then specifically the bottom half is discussing bone. Is bone resected? Is the soft tissue debrided? Or is the bone culture or histology positive at the margin? And they recommend 3 weeks if the margin's positive, but if no surgery or dead bones present, they recommend 6 weeks. And they specifically say, as treatment with oral antibiotic regimens for residual osteomyelitis are associated with failure rates similar to those with intravenous regimens, this may help reduce the length of hospital stay in those patients. So they're quite clear that intravenous antibiotics do not outperform oral antibiotics for diabetic foot infections with osteomyelitis. And so this is a sort of amalgamation of the guidelines in a one-pager that we use at NMC. We have categorizations at the top. We talk about collecting cultures in the middle here. And then for the various severities, we came up with regimens that our group preferred there. There could be several options, but this is what we preferred at our institution. And then here we talk in the bottom right about how long to treat based on what's going on surgically and what was found with bone at the time. And we specifically endorse that oral therapy after inpatient parenteral therapy is usually feasible, even when residual bone infection is present, and consider ID consult for regimen selection. So we're working really hard to narrow the empiric regimens, to shorten the durations, and to use oral, not intravenous antibiotics for these patients. So why would these fail? Because I think many of us have seen that patients have been treated 2, 3, 4 times, and they fail and recur. And this is typically due to either inadequate offloading, bad vascular supply, or just inability to resect tissues all the way back to viable tissues. A lot of patients with vascular disease and diabetes just cannot heal their tissues and have microvascular disease, et cetera. And it doesn't matter what antibiotics you give, they're going to have problems. The guidelines are also clear that they suggest not using hyperbaric oxygen therapy or topical oxygen therapy as an adjunctive treatment because there's no data that it works. There's also no data that more than 6 weeks of therapy is useful. And what are some myths? These are things perhaps all of us have heard on occasion. I just thought I should directly address them. So here's quote, all diabetic foot ulcers should be treated with antibiotics. No, antibiotics specifically do not speed ulcer healing or prevent infection. Uninfected diabetic foot ulcers should not be given antibiotics. Here's another one, quote, all diabetic ulcers to bone require admission for IV antibiotics, close quote. False. If wound is to bone, that person will need surgery. If their wound does not look actively infected and they're stable, they need to be seen by a foot surgeon and they can have surgery performed. If they're sick, they should be admitted. If they're having fevers, if they're having redness rapidly spreading up the foot, or if they can't tolerate oral antibiotics, then they will need to be admitted and something will need to be done immediately. Okay, next, quote, all inpatient diabetic foot infections should be given vancomycin and zosyn to cover MRSA and Pseudomonas, close quote. False. We went through the national guidelines and the recommendations for it. If a patient has known MRSA or Pseudomonas recently from that wound, those need to be covered. If somebody's septic, meaning they're sick and they have life-threatening infection, then yes, they need coverage for all those organisms, and they need an urgent surgical assessment for source control. And then the last one, quote, all osteomyelitis requires a PICC line and 6 weeks of IV antibiotics, close quote. We still see many instances and get many calls where we're called after a PICC line's ordered or put in because a patient had an X-ray abnormality of a small toe, and the team has decided that a patient needs 6 weeks of IV antibiotics. This is false, 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 which I've been through based on the guidelines and the literature and the rationale that I outlined there. Okay, now here's a corollary that's kind of similar to diabetic foot infections, which we also see a lot of, and that is osteomyelitis complicating sacral pressure ulcers. And this paper says whether or not to treat with antibiotic therapy. And this is from one of our stewardship gurus, Brad Spellberg in LA. And they did a very large review of this process and clearly show that systematic reviews demonstrate no benefit of antimicrobials without wound debridement and soft tissue coverage. So exposed bone on a sacral decubitus wound is often not infected when it is sent properly for pathology and cultures. And MRIs virtually always show abnormal bone in these ulcers and are not accurate for diagnosing osteomyelitis in a sacral decubitus, and probably really just shouldn't be done. So the thing to do is a wound care evaluation and assess for closure of the wound. If a patient has illness where there's soft tissue redness, induration, pain spreading around an infected looking ulcer, they have a soft tissue infection, and this paper recommends that treatment for 7 days should be given and then stopped. And it should be stopped unless a bone infection is proven and the wound is to be prepared for closure. Simply giving antibiotics for bone infection under a sacral decubitus wound is not beneficial or curative and is not recommended. If osteomyelitis is confirmed and the wound's closed, this review suggests that treatment for 2 weeks with oral therapy if there's cortical bone involved, and 4 to 6 weeks if there's medullary bone involved is recommended. And that's based on the pathology at the time of surgical wound preparation for closure. Okay. Lastly, we should talk about skin and soft tissue infections in drug users. I don't know that it's good exactly, but I think we could say that there's been a pretty sharp drop-off in severe skin and soft tissue infections in IV drug users in Alaska, and it appears to be correlated to fentanyl availability and decreased heroin availability. And in fact, the needle exchanges are handing out substantially fewer needles the last couple of years as fentanyl has supplanted heroin in our communities. The reason that severe infections occur is injecting drugs is rarely a sterile process by which there are nursing, Lippincott, and other competencies performed. Many users lick their needles as a lubricant for dull needles, or they suck the injection sites or lick the injection sites, and that's not good. You shouldn't do that. So the common things that we see are anticubital fossa abscesses, can see cellulitis with actually infected or very firm inflamed clot in the veins, and necrotizing fasciitis. Most of these are beta strep or Staph aureus as per usual soft tissue, but oral flora can also be in there if people are licking their needles or the skin, such as Eikenella, anginosus strep, or Prevotella. However, there is literature specifically on how to treat soft tissue infections in drug users, and they specifically recommend that vancomycin monotherapy, as an example, is adequate. Empiric coverage for oral flora is not shown to be beneficial or required. We do sometimes add ampicillin and sulbactam for severe skin soft tissue infections in these patients, though, but the literature wouldn't really suggest that that's required. So at one of our hospitals, we now have a chemical dependency service, which is just wonderful, or addiction medicine service, and they've been very helpful. We're helping patients with resources and medication-assisted therapy so they can reduce their injection use. We also want to instruct them about using antisepsis prior to injecting and how to, not lick needles, touch the injection site, et cetera, give them needle exchange information, screen for STIs, including HIV and hepatitis and syphilis. Injecting drug users should be offered pre-exposure prophylaxis for HIV, although I'll admit the uptake is very poor for that right now. And if they're using opiates, a naloxone rescue kit is important because it saves lives. And with that, we've got, yep, it's about 45 minutes, so that's pretty good. Here's all the resources here. And then let me just get out to the meeting. I'm going to stop sharing my screen so I can see people. And we can try to take any questions, either come off audio or in the chat.
Hi, Dr. Westley. This is Jenny over at Providence. Thank you for that. That's fabulous information. I learned a lot. Could you tell us a little bit about patients that maybe have osteomyelitis or a deep skin infection? They're on antibiotic therapy, and then what the management would be after amputation of the site, and if it's MRSA and colonization, if there's any considerations with that.
Well, if they have MRSA in a toe and the toe is amputated, then the infection should be down in the pathology lab. And if they were cut at a clean area, then the infection may be gone. So normally people just get a couple more days of antibiotics. Though if you cut a toe off, but the skin is red up to the shin, then there's still cellulitis there, and we would treat people for the soft tissue infection for, a week or so. So hopefully that gets at your question. If somebody's amputated with clean margins, then the infection's gone. If they have a infection on their heel and they get a below knee amputation right through the shin, then the infection's gone. And those people, like for example, the diabetic foot guidelines say that they can just be given 2 days, couple days of antibiotics and then stop. So I don't know if that answered your question, Jenny.
Yeah, it does. It's just kind of helps when we're looking at charts afterward, just what to look for. Thanks.
Yep. Other questions about these? When you say recent history of MRSA or Pseudomonas, how far back are previous cultures relevant? I mean, 3 months, couple months. If somebody's real sick, you're going to need to cover them anyway. If they're not that sick, it's not super critical. Normally, somebody's MRSA, they could be colonized for a year, a couple years. Pseudomonas comes and goes. Pseudomonas doesn't usually make people super sick when it colonizes an ulcer anyway. So the main question is whether you need MRSA therapy or not. And there's not a great way to know that other than culturing the wound. I would like to see some literature on rapid PCR of the ulcer simply to rule out MRSA directly from the site. But that literature is lacking, and right now the national guidelines actually don't recommend doing any molecular testing on those. The other question is about nasal screening. The literature actually evolved, and for just all forms of soft tissue infections, a nasal MRSA PCR now looks like it's probably about 85% sensitive for ruling out an MRSA skin and soft tissue infection. But that's probably not adequate for diabetic foot infections, certainly not adequate if somebody's really sick. So right now, nasal MRSA screening isn't part of the national diabetic foot guidelines for avoiding MRSA treatment. But again, MRSA treatment's only needed if somebody has already been demonstrated to have it or if they're severely ill.
There was another question.
Yeah.
And I had a bunch of stuff next to it. So
there's one from Megan with the diabetic foot. Diabetic foot with osteo, there's not been surgery and 6 weeks of antibiotics are indicated. Are you using high doses of PO antibiotics or still using IV therapy? We are not using IV therapy for diabetic foot infection with osteomyelitis anymore, really, unless there's an organism somehow that is not susceptible to an oral antibiotic. I wonder how the definitive diagnosis of diabetic foot osteomyelitis was made without surgery, though. I guess it would be either probe to bone or X-ray changes without surgery, and that is a little bit challenging. So it's basically assumption that there's bone involvement there, and therefore treating for 6 weeks. The salvage rates for forefoot diabetic osteomyelitis are acceptable. So for a small toe or distal metatarsal, if the tissue is alive and salvageable and appears to be healing in the hospital with IV therapy and wound care, then treating with 6 weeks of therapy, oral therapy, is a recommended approach in the guidelines. So the guidelines are quite clear, in fact, that they do not recommend cutting off every toe or every metatarsal that happens to have X-ray changes. That needs to be done if the bone is necrotic, soft, not viable, not responding to therapy, etc. Forefoot, so distal foot. Okay. Oh, there's Anna's. Oh, good. So Anna added the data on the strep susceptibilities. Okay, great. Any other questions?
Madeline posted one.
Oh, here's one. I would see a fair amount of Bactrim plus cephalexin and providers stating they wanted the latter for strep coverage, implying Bactrim doesn't adequately cover strep. Could you please repeat what you stated about cephalexin being unnecessary addition? Yes, cephalexin is an unnecessary addition to Bactrim for non-purulent cellulitis. The study I showed you of Bactrim versus clindamycin was about half purulent and half non-purulent disease, and the outcomes were equivalent between Bactrim and clindamycin. We have pathways for skin and soft tissue treatment at Providence and Native, which I'm sad to say many of the ED docs still don't follow, and they do not include Bactrim plus cephalexin. Bactrim has adequate beta hemolytic streptococcal coverage for outpatient treatment. The cephalexin does not need to be added to Bactrim. Is the LRI NEC score useful for immunocompromised patients given potentially lower CRP values? Those patients I don't think were ever included in the initial studies of that score. So I would be hesitant to use an LRI NEC score in a stem cell transplant patient or a kidney transplant patient, for example. All the references are in the slides. So every reference that I mentioned here is in the slides with numbers, so you can figure out which reference you want to pull. Katie says that in the urgent care and walk-in clinics, it's hard to get providers to do incision and drainage and not just throw antibiotics and expect them to get better. So I don't know if you mean with a furuncle or carbuncle, like a MRSA abscess in the arm or something, or if you mean a diabetic foot, but I also find it interesting that doing less work seems to trump doing more work in many workplaces, and it's more work to incise and drain something or culture something than to not do it. But it definitely hampers the providers following up later when somebody's not getting better or they're having a side effect to the antibiotic they were given and you don't know what organism you're treating. So getting source control and getting cultures is pretty critical when you're treating this stuff. Any other questions? Okay, looks like that's about it. Thank you everybody for listening.
Yeah, thank you all for coming. Our next session is on March 5th on stewardship and urinary tract infections. I hope to see you on, and we'll be sending out the recording and all those slides a little bit later today. Thank you all for coming.
Thanks. Okay, bye.